25, and then also Forbes 30 under 30. He led a telemedicine startup in Kenya and built a digital patients pathway solution for private healthcare, which he's going to talk more about. After spending a large portion of the pandemic working in an ER ward, Wojciech returned to his passion of working up the frontier of humanity's technological progress. I am just envious with such an intro, Wojciech. That all sounds amazing. Wojciech is running a company called DataLake, and he wants to talk further about DataLake, also very much in line with what Binod said about how that works. His presentation has two titles, actually. Creating a patient registry with Web3 principles, and he's going to give us a case study around that. But at the same time, Genomes, DAO, and DataLake are working together on something called the Data Donation Manifesto. And I was hoping Wojciech could also talk a little bit about that. So without further ado, we're going to take it to Warsaw, where Wojciech will be talking to us. Thank you so much. Wojciech, the floor is yours.
Thank you, Aldo, for this wonderful introduction. I'm thrilled to be a part of this event. And as you have said, I'm hoping that I will be able to deliver a good blend of scientific knowledge and entrepreneurial knowledge. During today's presentation, I'm going to focus specifically on one of the case studies that we recently did as DataLake, launching a patient registry for a rare disease called acid sphingomyelinase deficiency. Absolutely, I'm also going to refer to the Data Donation Manifesto and the Data Donation Principles, because as you're going to soon discover, patient registry is nothing else than a structured, curated, periodically updated database that in the case of our registry is also being built using the principles of data donation. So let me just share my screen and make sure that everything works there. Aldo, can you just confirm that everything is all right?
Yes, yeah, we can see your slides, and I hope people in the Zoom meeting can as well. I think we're all good. Yeah.
Magnificent. Amazing. So guys, we are going to talk about rare disease patient registry, and by extension, about ethical use of data for improved patient outcomes. So for those of you who may have never encountered a term as such as rare diseases, I'm going to give you a brief rundown through the problem. And the problem is actually of a bigger magnitude than we tend to think, certainly of a bigger magnitude than I found out when I was still in my medical school. And there's a number of challenges in the area of rare diseases. So first of all, it's estimated that 6 to 8% of the world's population actually suffers from some kind of rare disease, which translates to 3.5 million people in the UK alone. Which is actually quite stunning if you think just about the sheer number and sheer volume of patients. Patients are, however, vastly invisible in the system. There are only 250 ICD-10 codes. Codes that help doctors put a number and put a structure to the patient's diagnosis. And most of the patients actually also go through something that's called a diagnostic odyssey. So they seek diagnosis, they seek to be diagnosed for many, many years. And on average, a diagnosis is typically made by only the 8th specialist that the patient meets, if they are lucky enough to be diagnosed at all. And usually it happens after 2 to 3 incorrect diagnoses. And that's one of the reasons why these patients are invisible in the system, because most of them are still undiagnosed, most of them are not coded, and most of them actually fall under many different diagnostic codes, many different conditions, because we have over 8,000 rare diseases. So it's also not possible for medical doctors to be well versed and to be knowledgeable about all of them. And most of the rare diseases, as they have some form of genetic background, they are also multi-systemic. So patients suffer from gastric disorders, from cardiac abnormalities, and they have malfunctions of different bodily systems. And therefore, by extension, these diseases are multidisciplinary. So there are a lot of specialists that are taking care of the patients. So what we see here is the tip of the iceberg with the actually estimated magnitude of the problem being much bigger than what we tend to see in the system and in the statistics in the healthcare industry. So rare diseases are actually a very interesting case to create patient databases and to be able to track those diseases better, because right now we just simply lack enough information to be able to diagnose these patients more efficiently and to be able to reach diagnostic consensus for every single disease. And that's why patient registries are a very interesting case for examining these conditions. Patient registry is nothing more, as you see, than a structured database that collects, stores, and manages patient information, which is usually focused on specific health conditions, such as a disease, or a medical procedure. So, for example, all the patients who underwent transcatheter aortic valve replacement. Registries are commonly used already in clinical practice. They are used for disease monitoring, for epidemiological research, for treatment effectiveness evaluation, and for improving healthcare quality. So one of the examples that I like to quote to be able to show how registries shape the understanding of rare diseases and clinical practice is a rare disease registry in a disease which is called a Gaucher disease, which is a lysosomal storage disease. It's also a rare disease where the treatment was introduced a couple of years ago. And there is a registry operated by the International Collaborative Gaucher Group, ICGG, Gaucher Registry, operating since 1991 with 700 centers with 12,000 patients included in the registry from 60 countries. So what was achieved based on the findings of that registry is actually quite remarkable, because of this research and the amount of patients and the richness of data that was collected. Clinicians were actually able to develop guidelines for evaluation and monitoring of Gaucher disease. They were able to define therapeutic goals for patients with type 1 disease. And they were able to produce various tools for both clinicians and patients, all of which is frequently not possible even in much more common diseases. But because of good quality, diverse, multi-center data, in this case, it was actually possible to reach this kind of diagnostic and therapeutic consensus. So registries were commonly and still are commonly used in clinical practice for a variety of different conditions, but they can also serve as a very interesting source for the development of AI. So traditionally, registries were used for clinical studies, for epidemiological and populational studies, but because they are also essentially well-structured, periodically updated databases, they can be used for training of AI algorithms, which in turn can unlock a number of different positive effects on the disease, such as, if we go down the patient path, reduce the number of incorrect diagnoses. And as you already know, this is a frequent problem in all of the rare diseases. We can actually get to diagnose patients earlier by comparing the patient's profile with profiles of diagnosed patients. We can risk profile the patients. We can create an individual risk profile of every patient by comparison with other patients in the registry. We can develop personalized diagnostic and therapeutic pathways. We are going to be able to continuously monitor and detect early warning signs. And possibly, we are also going to be able to provide better long-term care management by scheduling follow-ups and monitoring treatment. So as we all know, a common challenge in developing AI algorithms for specific use cases is lack of data. So the question is, can we actually leverage the potential of AI in rare diseases thanks to registries? And in my opinion, this is an excellent way to go because a patient registry meets many criteria that make it an ideal database for training of an algorithm because it's complete, it's structured, it's standardized, it's periodically updated. It's ideally based on patient consent, about which we are going to talk more in a second. And there is usually some form of governance that coordinates interests of various stakeholders, for example, sponsors, industry leaders, care providers, and patients. So what does it take to develop a healthy AI algorithm? So first of all, algorithms have to be ethical. They have to be specific enough and sensitive enough. So the first thing that we are taking care of is ethics and privacy. So all the data collection exercises should be based on patient consents, and patient autonomy should always be respected. Patients should have control over their data. Data access rules should be made public, transparent, and managed by independent institutions. There's also the quality of data aspect, and the data for algorithm creation should be from identifiable source, so we know where we get the data we are using to train the algorithm. It should be structured according to international guidelines. It should be ideally mapped to international standards. It should be complete from many different centers where patients were treated. And ideally, it should be longitudinal, so from multiple points in time. So if we double click on patient privacy and patient rights, there are a couple of things that are important here. So first is the patient consent. As you may know, there's a lot of debate worldwide about whether patients' data for research should be used in an opt-in model, where every patient gives their informed consent for being a research participant, an opt-out model, where the patients are given an option to resign from participation in research, but by default they are actually included. Or there should be no consent or information at all, which is sometimes called a no consent model, where patients it's not even aware that their data is used for research. With rare diseases particularly, I think this dilemma is much easier to solve. Because first of all, there are difficulties in anonymizing data of patients with rare disease. Even if we delete the patient's personally identifiable information, because those diseases are very specific, there are challenges in anonymizing patients' data successfully. And therefore, patient consent while dealing with personal data is usually required. For many studies, we actually have to be able to contact the patient every now and then, for example, to invite them for a scientific trial, to draw a blood sample, to be able to ask the patient about quality of life indicators. And if we need to contact the patient, once again, a consent for contact is also required. There's a lot of debate as well about auditing of a consent in research. Therefore, consent should be auditable. And of course, there should be a possibility for patients to manage access to their data, namely withdraw a consent whenever they find it applicable. Because at the end of the day, we are talking about a data collection exercise that serves patients. There should be wide community involvement. There should be buy-in from patient associations. And usually there is also an independent scientific body that's curating the database and paving the way for research, indicating the direction of the research and supervising data access requests. Last but not least, data access should be transparent. So there should be clear and accessible data access rules. Everybody should know how we actually, as a registry, how do we handle the data access requests. And ideally, there should be a non-profit organization as the administrator, as the controller of the patient's data. Double clicking on data quality, there is stress should be put on completeness of data, which can be handled by engaging a professional entity to collect data and relieving the burden from clinicians and patients. So nowadays, most of the registries actually rely heavily on collection of data by clinicians and patients. It's not ideal because, as you can imagine, both patients and clinicians are very busy. It's not their main job. It often generates incomplete data sets or it generates unnecessary delays. Collection of data should be done directly from medical databases to relieve the burden from patients. Ideally, it also should be done based on patient authorization. There needs to be the possibility of combining different data sources, both clinical and patient data, which is usually done by sourcing and authorization from a patient. The second important issue is standards and structure, which is a technical thing, so I'm just going to briefly skip through it. But generally, it's about defining mandatory and optional data elements. It's about updating the data periodically. It's about having data quality management procedures in place. And it's also about normalization and standardization according to international data standards. Amazing. So we know what are the key principles of creating a registry. So first of all, it should be ethical. It should be done with clinicians and with patients on board. It should be based on a good quality data set. So we are actually thrilled to share with you a case study of a rare disease registry that we are as DataLake we are creating based on these principles. In this case, we are a registry operator, so we are doing all the heavy lifting of managing the scientific council, of managing patient recruitment, of liaising with a sponsor, and getting patronage and support from a variety of different stakeholders. We are privileged to work with 6 different patient associations and patient advocacy groups in this project, including some of the biggest names in Polish healthcare. And the whole project is sponsored by a pharmaceutical company, which is Sanofi. The goal of the registry, wait a second. Amazing. The goal of the project is to create a registry enabling the analysis of diagnostic and therapeutic pathways of patients with acid sphingomyelinase deficiency, and to develop AI algorithms for more effective disease diagnosis. Project is called PASMO, which is an acronym for Patient Pathways ASMD Optimization. We divide the project into a couple of stages. So first, there was the stage of selection of registry operator, which in this case is us. We are responsible for project management, for patient recruitment, and for data structuring. This was followed by a preparatory phase, which was about understanding the legal environment, getting on board key opinion leaders. We are fortunate to work with more than 10 wonderful scientists and clinicians that form the scientific board of this registry. Then we developed a registry protocol, which is compliant with the good registry practice and the guidelines from both the American and European agencies. Right now, we are during the patient recruitment phase, so we are reaching out to patients and convincing them that it's worth a while to join the registry. This is going to be followed by a data structuring phase, so a mundane work of structuring the data from medical records to a structured form, and hopefully publication of results and further scientific work. What's critical from our experience in developing a patient registry is involvement of scientific community. In our case, we managed to gather a number of experts, both from the clinical side, but also legal, systemic, and AI sides. The Scientific Council is essentially an independent body, independent from us, from the registry operator, with its own governance procedures, and it both curates the data set and guides the scientific endeavors of the registry. Experts also help us to establish an appropriate data structure for us to know what is actually important and useful to know about patients with this condition. Patient recruitment is, of course, critical. By patient recruitment, we mean getting patients on board, getting them to agree to donate their data for a patient registry. This is actually done through multiple channels. We work with some patient organizations who are reaching out to their members and offering them participation in research. We are also working with centers that are treating and diagnosing ASMD patients. We are always providing complete and understandable information for patients about the registry. We are also making available our technology for informed consent management for the patients to be able to modify the data and withdraw consent at any time. Of course, we also use blockchain technology for auditability of patient consents. So every single operation on the informed consent is auditable thanks to our DataLake application. And we are using the system for coordinating all the patient recruitment efforts. There's always the question of access to data and where do we get the data from to be able to create a comprehensive and good quality data set, which is a challenge because patients with rare diseases, because they take so long to be diagnosed, they often go from one center to another, and therefore we have to reach out to 5 or 10 different medical centers to procure medical data of these patients. What makes this exercise a little easier is that the sample size is relatively small here, so we are aiming to include only 30 patients in this registry. Data collection is done both directly from facilities, so we are authorized by the patients to fetch medical records on their behalf from hospitals and clinics. But the documentation can also be sourced directly from patients, most often in a paper form. So we are just asking patients after they gave their consent to mail their medical records to us, which is followed by data structuring and mapping the data to the registry standard, which is right now mostly manual. And it's the most cumbersome part of the registry development. There are also specific legal challenges that we face in case of minors, people who are under the age of 18, and patients who are incapacitated, which unfortunately is frequently a case with patients who suffer from incurable diseases. But it's also possible to overcome these challenges by working with attorneys and developing appropriate consent forms. There is a new paradigm of data access coming up in the European Union. One legislation has already been enacted. It's called the European Data Governance Act. The other one is currently being processed, which is the European Health Data Space. However, in both of them, a general philosophy of the European Union about what they call secondary use of data, so the use of data for research, is the same. So it should be done in the spirit of data altruism and based on patient consent, which is nothing more than the data donation that Aldo mentioned at the beginning of the presentation. So we are starting with a rare disease registry, but we hope that our vision can be extended for other therapeutic areas. And we would like to replicate our model in other rare diseases internationally and also in other health conditions. So to reiterate, the key assumption of our model are that we are empowering patients through data access management technology, through our informed consent management technology, to be able to actively involve patients and patients' organization at every stage of the work. We always promote an independent registry governance through the Scientific Council of clinical, regulatory, and data science experts. Data processing is transparent using blockchain technology. We are basing the registry on the latest EU legislation. We are also drawing heavily from the international good registry practice guidelines, such as the American Healthcare Research Quality Organization or Parent and Request guidelines. And we always put a strong emphasis on data quality and compliance with international standards. Last but not least, where it all leads me is why using Web3 principles in registries actually makes sense. So there's been a lot of debate and a lot of trial and error also on our side as an organization to find a model of integrating Web3 principles with data capture, data sharing exercises, right? And with the registries in particular, I think that Web3 mechanisms essentially fit very well with good registry practice standards. So as you see, a registry is essentially a data set, right? That we curate, that we upload periodically. It has certain value. And there's also a strong element of governance over that data set, with decisions regarding scientific access, with decisions regarding ongoing operations of the registry, patient recruitment, engaging external stakeholders, and so on. So Web3 can be definitely helpful here by establishing governance mechanisms, possibly through governance tokens. Web3 could also provide a funding source for a registry, and therefore using Web3 principles for building patient registries could actually be a sustainability mechanism for not only starting but also developing the registry over the years and incentivizing different participants to be of support for the registry. Using Web3 can also stimulate cooperation between different parties such as academia, industry, and patient representatives. It brings transparency of data processing and of informed consents, which is of vital importance for any kind of registry, for any kind of curated data set. And last but not least, it gives the organization or a decentralized autonomous organization custody over data, not to be confused with ownership. So generally in the European Union, we usually don't talk about ownership of data. There is no such notion in, for example, General Data Protection Regulation in GDPR. And that's for a reason, because at least in the European Union, we do not talk about ownership, we talk about custody, which comes with certain rights. So for example, to be able to process the data, to be able to give access to data for external parties, but it also comes with certain responsibilities, right? So the responsibility to maintain the data set secure, to comply with patients' rights, and so on and so on. So we are hoping to show an interesting model that can be replicated for many other data sets. And what we essentially envision is creation of registries using Web3 principles, funded via cryptocurrencies, governed by a DAO or using governance tokens that can be platforms for cooperation between pharmaceutical industry, between academia, between patient organizations, and independent scientists. And that would be all. Thank you for your attention. I don't know whether the formula of the conference actually allows for questions and if we have enough time, but if there is, I'll be happy to answer.
Any questions? Yeah, one question there.
Yeah, I don't know how to pronounce your name. I'm trying now. Wojciech, right? Yeah, I love what you have done. And how easy was it to create this database? So that's the question. How easy was it to create this database? And
easy is not a word that I would use. If that answers your question.
So how long? What's duration? And then especially the Web 3.0 side of things. And I'm looking at, you said, I think you said you have worked in part of Africa called Kenya, right? So if we look at some part of Africa where they don't have, they are still using the paper-based database. So how can we digitalize those stuff so that it will be easy to track the records of patients so that better way to organize? And I'm sorry, I'm a nuance to Web3. What about the security of those things? Can't it crash? Because if something crashes, all of that, then the whole system. So what's the security side of things as well?
All right, so it's actually a couple of questions. So the first one was about a level of difficulty in creating a patient registry. And so far, what has been most difficult for us is securing funding, and this took us the majority of time. This registry is funded by a pharmaceutical company. It was not community founded yet, but we hope to fund next registries via a community Web3 mechanism. So if we are able to fund the registries easier, then that would already have removed a significant bottleneck from developing this project. When it comes to data collection and patient recruitment, it is also alleviated by having a budget for it. So if you can pay clinicians for doing the work and identifying the patients for you, then it makes it easier. We are right now in the patient recruitment phase, so we don't have the database yet. So it still remains to be seen how much work and how many challenges there will be in curating the data. And to answer your last question about security, we are using blockchain only, or only in quotes, in brackets, for management of informed consent forms. So we are not storing data sets on the blockchain. They are stored independently, and the blockchain is used for audit trail and management of informed consents. So the data sits securely on private servers in that regard. And blockchain is used and publicly available to be audited only in the aspect of consent.
Thanks.
Any more questions? Could you briefly talk a little bit about the data donation manifesto?
Absolutely.
Addressed it, but just as it is also something that we collaborate, I'd love for you to talk a bit about.
Absolutely. So where I was heading with the presentation and with the main thought is that at the end of the day, we are implying we are using the data donation principles for creation of a patient registry. So what data donation is about an informed decision of a patient to be able to donate their data for science. And currently, a legal mechanism of doing that is by giving what's called an informed consent and or authorizing a third party to access your healthcare data on your behalf, right? So in that regard, it's very similar to blood donation or bone marrow donation or whole body donation or other donation systems in healthcare. But in this particular case, you're not donating your tissues, you're not donating your bodily parts, but you're donating your data sets. So of course, this whole project is based on that principle. So patients actually are given a chance to willingly contribute or donate their data for research. As for now, they are not being compensated for that. They are just given the tools for management of their data set. And we actually see a very big uptake and very encouraging conversion rates from patients. So up until now, all the patients with this particular rare disease whom we approached and asked to donate their data for the registry agreed. So there is also this kind of appetite, if that's the right word, for patients to contribute to research and by extension, contribute to finding more effective treatments for the disease from which they suffer. And you also have to bear in mind that specifically in rare diseases, patients have been neglected for many years. The other word for rare diseases is orphan diseases, because they were largely neglected by the government, by funding agencies, and by pharmaceutical companies. So what patients are looking for is to be noticed and to have some form of control and of taking action against the disease. So to answer your question simply, Aldo, this is a data donation manifesto in practice, in a very specific use case of a rare disease registry.
And I've heard that in some countries, even if the patient would want to donate the data, sometimes they're not allowed. Is that correct? Which was just mind-blowing to me, that you're in some cases cannot even make that decision for yourself.
Yes, that's true. However, we are fortunate to live in the EU or in the UK, where that's 100% possible.
Yeah.
Same mechanism works in the States, and in most of the countries I've been working in or with whom we are collaborating, this is definitely possible.
Okay. Any further questions for Wojciech? No. Well, then a big thank you to you there, Wojciech. It was very. I've learned a lot. Yet again, we've tweeted about it, so check those out. Thank you so much for doing this, and looking forward to the next project or adventure we do together. Thank you so much.
It's been an honor and a pleasure. Thank you for having me.
Thank you. Take care.
Goodbye.
Bye-bye. So we then right away have another presentation, but we would allow maybe just for the logistics to get you set up.
Yeah.
5
minutes. 5 minutes.
Yeah, I would. Yeah, maximum 5 minutes for people for bio break, if you want to, just to get everyone set up for an in-person talk from Professor Alistair Mackenzie. So yeah, we'll regroup in 5 minutes while we get everything set up. So yeah, also yeah, the slides. Let me make sure. Slideshow. There's a slideshow. No, it's a slideshow. Is it on? Yeah, it's on. Okay, it's. I think it's that. It's I think. Yes. Yes. Okay. I saw. Okay. It's good stuff. That is fun. We do. I could get small. Let's just back. We're gonna have what size?
It was Albert and cannot speak, so we push their workshop forward.
Yeah, I think what we should do is we should just be a bit more flexible in the workshop.
Okay.
So we should take some more time